Good afternoon. I'm Cherie Dotson, Student Affairs Program Manager for Recruitment in the College of Pharmacy and Chair of the 2022 MLK Health Sciences Committee. And I am pleased to welcome you to our 32nd annual MLK Health Sciences Lecture. Please note that closed captioning has been enabled for this webinar and can be accessed by hitting the live transcript button in your Zoom toolbar. Before going further, we would like to acknowledge that the University of Michigan, named for Michigami, the world's largest freshwater system and located in the Huron River watershed, was formed and has grown through connections with the land stewarded by Nishwe, Ishigadawan, Anishinaabe, the Three Fires people, who are the Ojibwe, Ottawa, Potawatomi, along with their neighbors, the Seneca, Delaware, Shawnee, and Wyandot nations. The members of the MLK Health Sciences Committee represent the schools and colleges of dentistry, kinesiology, medicine, nursing, pharmacy, public health, and social work, with dedicated representation from the Office for Health Equity and Inclusion and the Michigan Institute for Clinical Health Research, as well as organizational learning. The names of our MLK Health Sciences Committee for this year are listed on this slide for acknowledgement. The names of individuals within the College of Pharmacy who were also vital and helpful in the planning of these events is also listed here for acknowledgement. Each year, members of the Health Sciences Committee come together to plan programming in honor of the vision and legacy of the Reverend Dr. Martin Luther King Jr. In addition to our highlighted keynote lecture, the committee has been dedicated to planning other events throughout the year to engage our health science community around topics that are central to the vision of Dr. King. This year, we will host an interdisciplinary panel discussion focused on the ethnic and racial disparities in pain management, as well as several book dialogues on the book Medical Apartheid, written by Harriet Washington. Additionally, as a follow-up to this event, our health sciences students will have an opportunity to network with our keynote speaker, Dr. Lakesha Butler, later this month. Please see the link in the chat to register and for further information. All of the work that we do could not be possible without the continued support from our health sciences deans. And we have been doing this for 32 years. And so we want to acknowledge our deans past and our deans present for their support and continued commitment to these efforts. And our deans are listed here. At this time, I would like to invite our interim dean, Bruce Mueller, to provide welcoming comments on behalf of the College of Pharmacy.
Hello, everyone. Hello, everyone. On behalf of the College of Pharmacy, we're pleased to have the opportunity to serve as the lead unit for the 32nd annual Martin Luther King Health Sciences Program. I'd like to thank the MLK Health Sciences Committee for their hard work in organizing this event, with a special thanks to our College of Pharmacy representatives, Cherie Dotson, Kelly Archer, and Regina McClinton, who have been working with the planning team in the hosting of this event. Our theme is, This is America, Confronting Health Inequities and Writing Prescriptions for Change. Pharmacists are known as the most accessible healthcare provider, as you can find a community pharmacy in just about every neighborhood, and you can talk to a pharmacist anytime that a pharmacy is open without an appointment. Pharmacists can utilize their position to collaborate interprofessionally and serve as local healthcare disparity agents of change. I'd like now to invite Dr. Paul Walker. He's our Assistant Dean for Experiential Education and a clinical professor of pharmacy, to introduce our keynote speaker.
Thank you, Bruce, and good afternoon, everyone. It is my distinct pleasure to introduce our speaker today, my colleague, Dr. Lakesha Butler. Dr. Butler is Clinical Professor of Pharmacy Practice and Director of Diversity, Equity, and Inclusion at Southern Illinois University, Edwardsville School of Pharmacy. She is also the CEO and founder of Dr. Lakesha Butler, LLC, a consulting agency whose mission is to disrupt and to dismantle inequities and injustices in healthcare and in higher education. Dr. Butler is the immediate past president of the National Pharmaceutical Association and chair-elect of the Council of Sections of the American Association of Colleges of Pharmacy. Dr. Butler's leadership and impact span broadly at the school, institutional, and national levels, as well as within her community. She is a national speaker on the topics of anti-racism and diversity, equity, and inclusion. She is also the co-author of numerous peer-reviewed papers, including Systemic Racism, Pharmacists' Role and Responsibility, Holding Pharmacy Educators Accountable in the Wake of the Anti-Racism Movement, A Call to Action, and Developing a Framework to Address Health Equity and Racism Within Pharmacy Education, RX Heart. Dr. Butler received her Doctor of Pharmacy degree from Mercer University in Atlanta, Georgia, and completed a pharmacy practice residency at the University of Illinois at Chicago. She has received extensive leadership and DEI training and is a certified diversity facilitator. I'm sure we are in for an insightful, compelling, and engaging presentation. If you have questions for Dr. Butler, please put them into the Q&A, and we'll do our best to try to address them at the end of the presentation. Please welcome Dr. Lakesha Butler.
Thank you so much, Dr. Walker, for that warm and welcoming introduction. It is certainly my pleasure to be here with you all today. I will share my screen as we get started. I have a lot to say. This is a wonderful day, and I'm so happy to see so many of you here today. This, of course, is not a day off, it's a day on, and hopefully by the end of this presentation, you will have the tools, the resources, the motivation, the drive to continue to move forward as we confront health inequities and write prescriptions for change. So I want to talk about Dr. Martin Luther King, one of his famous speeches, and he has so many. It was titled The Other America. And in that particular speech, he says that there are two Americas. On March 14th in 1968, he described one America as beautiful, where millions have the milk of prosperity and the honey of equality flowing from them. Millions have food and material necessities for their bodies. They have culture and education for their minds. They have freedom and human dignity for their spirits. Children grow up in the sunlight of opportunity. But he talks about another America that has a daily ugliness that transforms hope into despair. Millions are forced to live in distressed housing and conditions. Young people are deprived of an opportunity to obtain an adequate education. And the most critical issue in America is an economic problem. The income is too low and jobs are devoid of quality. Unemployment is a reality. In this other America, occupants find themselves on a lonely island of poverty in the midst of a vast ocean of material prosperity. This causes bitterness, anguish, and angst. These two visual depictions that you see here highlight dark green areas of higher income, while the red map highlights areas of poverty that are densely populated by racial minorities. This shows a contrast of two Americas. Unfortunately, these two Americas that Dr. King spoke about 1 month before his untimely death in 1968, more than 50 years ago, are still a reality that describes every city in America. Every city in America has two cities instead of one. I often hear that the most profound racial injustices were hundreds of years ago, and everybody has equal rights now and have had equal rights for some time. However, I play a game of Monopoly with my students and university colleagues to show that the effects are longstanding and still manifest today. Let's imagine that everyone collects $200 when passing go, except anyone named Lydia. So let's go around Monopoly about 349 times and count up the money that each person has. I'll do the math for you. The Lydias have $0, and that's easy, but everyone else has $69,800. Now that we have done the math, the Lydias are causing an uproar. So let's change the rules. And now everyone, no matter your name, gets $200 when passing go. The Lydias should be happy, but if everyone passes go on the 350 a time, the Lydias still have $200 and everyone else has $70,000. Okay, let's give it some time and have everyone go around another 25 times. The Lydias now have $5,000 and everyone else has $75,000. The 349 times around the board represents the time of slavery and legal discrimination for Blacks from 1619 to 1968, when Blacks were able to legally live in the same neighborhoods as whites. The American pie is being eaten up by a select group of 20,000 in which the majority don't look like me. What we see if we were to split up the American pie is that the majority of that pie would go to that top 20% wealthy individuals. And the remaining pie would be split between the upper middle class and the middle class. And the remaining crumbs would go to the lower middle class and the poor class. Unfortunately, we're not able to all live the American dream because of these inequities. Let's imagine that you go to a restaurant around 9 p.m. with friends, and you are having such a great time eating, talking, laughing with one another that the time just flies by. The restaurant is no longer allowing patrons to come in because they are closing. The people on the outside of the restaurant are looking in, seeing that you and other people are still enjoying their meal, but they see a close sign. When they look inside, however, it looks open. They do not have access to the restaurant like the individuals inside do. You are on the inside wondering, why don't the outside patrons just come in? Because inside the restaurant, you can see an open sign, not knowing that the patrons on the outside see a closed sign and cannot access the restaurant like you were able to. Dr. Kamara Phyllis Jones, one of my favorite public health advocates, calls this a dual reality. Inequities and injustices structure an open and closed sign in our society. For those on the inside of the restaurant, it's difficult to recognize a system of inequity that privileges us, especially if we have never been on the outside of a closed restaurant that looks open. However, those on the outside of the door are very aware of the two-sided nature that exists. One of Dr. Martin Luther King's well-known quotes states that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. In 2022, we still have not moved the needle much on improving health inequities due to the social inequities. They continue to permeate our country. I want you to ask yourself, what have you done for those in need lately? Also, what have you done to fight against injustice? Or have you just gone with the flow? There are many current health inequities that I can share, such as on the left, the direct correlation of life expectancy at birth and the poverty rate. The higher the poverty, the lower the life expectancy. Or the health inequity of how racial minorities have the highest death rates due to chronic diseases, such as diabetes, heart disease, and cancer. Or how conditions, such as the skin condition at the top of your screen, is misdiagnosed in those with brown skin, because it is only taught using the picture on the right. Or conditions such as red man syndrome, a reaction that is drug-related. For my pharmacy individuals in the audience, it's usually due to vancomycin. But it does not show up as red in those with brown skin. Or how racial minorities are prescribed less pain medications than whites. Or the most recent inequities, with more than 2 times the deaths and hospitalizations due to COVID-19 in racial minorities. Even though we don't see the inhumane treatment of racial minorities, such as the gynecology experiments on Black women without anesthesia, or the Tuskegee syphilis experiment, or the non-consenting hysterectomy of racial minority women, or the stealing of Henrietta Lacks cells, medical racism and health inequities still persist today. They did not just disappear. Even though some may say it's not as blatant, it's now blamed on consequences of lifestyle versus consequences of life in America. So you may ask, all of these health inequities, what can I possibly do? Where can I start? The first step is to know and believe there is a serious problem within healthcare, but it's not enough to just know. We have to ask the question of what interventions can be made to address health inequities. What I have here on the screen is a socio-ecological model, and it's typically used in the public health arena. This particular model tells us that there are different levels of interventions that can be made. Some colleagues and myself, we have also adapted this particular model, not only for the public health arena or addressing these health inequities, but also addressing these inequities in pharmacy education. And this can certainly be transferable to all healthcare educational schools. This may look overwhelming and cannot be done by one person or a few people. These have to be tackled by a collective with consistency. We have individual, interpersonal, organizational, and organizational is very similar to institutional. And you'll see some similarities with community, public policy, and accreditation. So I will talk about most of these particular levels of intervention so that we, all of us in this Zoom room today, can take action in combating these health inequities. Starting with the individual level. The cycle of socialization is one of my favorite models because it really helps us to understand where we are as individuals What particular messages have we been told by loved ones, by the media, by institutions, by living in the society that we live in? What has been enforced through discrimination or rewarded, or the privilege that we receive? So typically, this particular cycle of socialization helps us to understand our biases. As healthcare providers, we go into this field definitely wanting to help people. And so it's not usually the explicit biases that we're most concerned about. It's the unconscious or implicit biases, those messages that have been etched into our minds, into our memory, into our hearts as the right way, and not necessarily knowing, or the way that we feel about certain individuals based off of messages that we received or messages that we didn't receive. It may be that you were told to stay away from a certain neighborhood. It may be that you only saw certain individuals that looked a certain way as your teachers or in certain fields. And so that unconsciously lets us know that anything other than what we have seen through our years of formation, that seems different. And it is unconsciously, it causes us to treat that situation or that person different as well. We can have a new awareness, or we can disrupt this cycle of socialization by raising our consciousness, educating ourselves, and attending sessions like today, wanting to have change or promote change. Or we can do nothing. We can continue to go with the flow and stay in this cycle of socialization. Oftentimes we stay in this cycle due to fear or just not knowing what to do. When we think about this self-awareness, and this is really a great first step of really understanding what messages we've been taught, what biases we have, there's also this level of thinking about, am I an anti-racist, or am I operating in anti-racism, or am I operating in racism? There's no neutral ground. And I've provided you with an abbreviated checklist to help you to think about how this may manifest in your life. Do you demonstrate knowledge and awareness of the issues of racism? Can you recognize your own limitations in doing anti-racism work? Do you raise issues about racism over and over, both in public and in private? Can you identify racism as it is happening? Are you making sure that anti-racism is part of the discussion when you're in different spaces? Can you attend to group dynamics to ensure that certain individuals are at the table and they're participating, those historically marginalized individuals? Do you strive to share power, especially with individuals that have been historically marginalized? Do you take a personal interest in the lives and welfare of individuals of different social identities? You may ask, well, why do we need to pursue anti-racism? If you remember, I previously posed, what have you done against injustice? Or what have you done lately to fight against injustice? Or have you gone with the flow? Scholar and educator Beverly Daniel Tatum uses the metaphor of a moving walkway at the airport to help us understand the ongoing cycle of racism. Active racist behavior is equivalent to walking fast on this conveyor belt. So this is a typical conveyor belt. Usually we see these in the airport. And so someone who's walking fast, they're moving fast on a conveyor belt, that would be considered an active racist behavior. The person that's engaged in active racist behavior, they've identified with this ideology and they're moving with it. However, passive racist behavior is equivalent to standing still on the walkway, as these gentlemen are doing in the picture you see. There's no overt effort being made, but the conveyor belt moves the bystanders along to the same destination as those who are actively walking on the conveyor belt. Some of the bystanders may feel the motion of the conveyor belt and see the active races ahead of them. They could choose to turn around, unwilling to go to the same destination. But unless they are walking actively in the opposite direction at a speed faster than the conveyor belt, unless they are actively anti-racist, they will find themselves carried along with the others. So I want to move to the curricular level, and I want to introduce you to Samantha Caldwell. Samantha is a minoritized pharmacy student and is experiencing trauma and frustration after completing multiple therapeutic classes on asthma, diabetes, hypertension, oncology. And in these classes, she's been taught about health disparities and how her race is the risk factor for all of these diseases in addition to others. She already feels isolated in the school and classroom because of the lack of diverse student representation. Oftentimes, she is talked over or ignored during group discussions. Her grades are declining, and she is mentally exhausted most days. She was also told by a professor that she was admitted because the university is trying to increase its student diversity. She feels isolated and as if she does not belong. This particular student may sound familiar, especially to my students in the audience. This is a real student that I have had the opportunity to speak with, and she shared her story. Can you imagine what she's feeling? How the isolation may be affecting her grades, maybe affecting how she shows up in the classroom, maybe affecting her health. And so when we think about addressing these inequities, it is important for us to also remember the education piece. As healthcare providers, we're also educators. In education, we have the responsibility to provide education to all in an inclusive manner. I've shared some strategies on the screen, and certainly I won't go into all of them, but providing affinity groups, a community for students that are traditionally marginalized or there are lower numbers of representation. Thinking about utilizing, I use an app called Name Drop. I can't tell you the number of students that have shared if I'm able to correctly pronunciate their name, how that causes them to feel seen and heard. The selection of groups and classes. So I've had some students to say, if the selection of groups are already predetermined, it helps them to not feel as isolated. Because if they have to find a group member, oftentimes groups are not willing to have them. They've already selected their friends, and that further isolates them. The other thing to think about is discussing the implications of the social determinants of health. So not just covering health disparities. So there are a number of health disparities that exist. Higher rates of diabetes, higher rates of heart disease in our racial minoritized groups. But why? Why does that happen? Not just stopping there. And if you are students, asking the questions of why does that happen? It's not just because of the color of your skin. There is so much more that has to be uncovered and discussed. Intentionally amplifying those marginalized voices in the classroom, using inclusive language, so not stating poor, but low socioeconomic class. All of these are strategies that you can implement right away and definitely create more of an inclusive classroom. I want to move to the interpersonal level and introduce you to a patient, Ms. Tara Lindsey. And this is a real patient of mine, but of course, this is not her picture. She's a 38-year-old middle school teacher with uncontrolled type 2 diabetes and hypertension. She's currently taking metformin 500 milligrams twice a day and lisinopril 40 milligrams daily. She has not followed up with obtaining her labs and has missed her last 2 appointments. Her last A1C was greater than 14% a year ago. She calls the clinic and states that she has an open wound on her back that is not healed. Her last blood pressure at home was 152/98. Her BMI is 36 and she's considered obese. This particular patient may be considered a difficult patient. And I would also encourage you to think about, even just viewing the patient's picture, what thoughts came up in your mind. Those first thoughts tend to be those unconscious biases that we may have. The information that I just shared with you is typically what we might receive from a patient's chart. However, there is more information that you may not typically gather during a healthcare encounter. Let me share some additional information. Her husband is away for military training. She has 2 children, and her aging father lives with her. She works another part-time job at the mall most days of the week to gain extra income to pay off her student loans and for extra money. She lives in a neighborhood that has dogs roaming, and she does not feel comfortable getting out for physical activity, nor does she often have the energy just because of her work schedule. She forgets to take her medications often because her health is the last thing on her mind. Plus, she feels fine. Her car is in the shop, and she sometimes uses public transportation or carpools with family members. She lives in a neighborhood that has few grocery stores, but many fast food restaurants, and she eats there at least 3 times a week. She experiences discrimination at work and discrimination in the community and larger society. Now, that additional information that I shared with you could be lumped under the social determinants of health. The social determinants of health are conditions in the environment in which people are born, live, learn, work, play, that affect a wide range of health, functioning, and quality of life outcomes and risk. Oftentimes, we don't delve deeper into these particular social determinants of health, such as education, healthcare access, the neighborhood and the environment that our patients live in, the social and community context, and the economic stability. Oftentimes, we may just focus in on the healthcare part of the access to healthcare and not even delve deeper into that as well. But some of the social determinants of health that our patient is suffering from include food deserts. The neighborhood that she lives in, she doesn't feel safe getting out and exercising. So even if we share with her the importance of getting physical activity, if we don't go into detail of what or how she can get this physical activity in her situation, it won't happen. She's in an under-resourced area. She is herself under-resourced because of those hundreds of years that I depicted from the Monopoly game that she is still manifesting in her family. There's also, she has the lack of economic stability, but also in her community and at her job, she is experiencing discrimination. So if you can imagine, all of these determinants of health are affecting her being controlled, and they're affecting her compliance or adherence to her medications. I also want to introduce you to this idea of racial battle fatigue and stereotype threat. Racial battle fatigue is the cumulative psychological, social, and physiological impact of racial micro and macro aggressions. It was a concept developed by Dr. William Smith in 2003. So just think about, for our patient, the racial trauma or the micro and macro aggressions that she may be experiencing and how this may be affecting her health. I can personally attest to the racial battle fatigue, feeling like I am constantly in a fight, doing the work of diversity, equity, and inclusion, but also the racial battle fatigue that I have experienced just being Black in America, being Black in my institution, being Black in my school, being Black in my clinic, being looked over for promotions, or simply being isolated and not having a community of allies or sponsors, receiving subpar student evaluations, being taught that people that look like me are at greatest risk for multiple disease states without discussing why, having to wait longer than most to be seen in the emergency room, it being assumed that I am on welfare, being followed around in a jewelry store, seeing COVID-19 hospitalizations and deaths wreak havoc in my community, seeing people that look like me being killed by the law enforcement. There are no positive outcomes of being scrutinized, criticized, and questioned. On the right, you can see the many manifestations on health due to racial battle fatigue. As we can see with our patient, her blood pressure was uncontrolled. And so it's not necessarily just due to the food that she's eating. We see these high rates of chronic conditions of individuals of racial minorities in America. But if we go to other countries and really assess their effects due to their race, we don't see these same effects. So this is America. This is the America that we're living in. The stereotype threat is a concept that was proposed by Claude Steele. The definition of this is anxiety arising from a person's awareness of a negative stereotype about a group that they belong to. It's the worry or concern about being perceived through the lens of a negative stereotype in the minds of others. So an example of this is for racial minority groups not performing as well on standardized tests, because that is a stereotype that has been passed down through society. And there is this fear or anxiety that arises while taking a test that I'm not going to do good, because that is the stereotype that exists. We see that in our universities as well. When we don't see as many people that look like us, there is this stereotype threat of feeling like I am meant to not succeed. And it can affect the way that we perform and show up in the classroom. Now, going back to our patient, Ms. Tara Lindsey, I shared with you some additional layers to her as an individual. And I really want to encourage you, as you are taking care of patients, or even as you are teaching our students to provide care to patients, we have to dig deeper into understanding the holistic patient. And this is a tool that I personally like to use, where it really assesses the social needs of the patient. These social needs help us to uncover particular barriers that are contributing to their lower health outcomes. They're contributing to their decreased medication adherence. So with this particular assessment, it helps us to understand and address how the social determinants of health can affect the patient. we want to ask the question of what has happened to the patient versus what is wrong with them. And that is more of a trauma-informed lens, understanding that our racial minoritized patients have undergone and that they are undergoing a lot of racial battle fatigue. They're undergoing discrimination. They're undergoing this fight to try to have more than what they have been able to obtain just because of the history of our country. It's also looking at these structural barriers versus stating that the way that someone is due to individual choices. With this particular tool, it's also important for us to think about building trust with our patients, listening to understand, seeking feedback from them, going to them with a heart of cultural humility. And what that means is I want to learn from my patient. I want to gather as much information from them because they don't know more. I don't know more about them than they do. I bring information to the table as a healthcare provider, but they can teach me so much more as it relates to themselves and us coming to an agreement on ways that they can help to improve their healthcare. I want to now move to the institutional and organizational level. Organization A on the right is made up of diverse individuals throughout, except for leadership positions. The organization serves a diverse community and prides itself in having diversity, equity, and inclusion within their mission, vision, and values. However, the minoritized employees and learners feel tolerated. They experience consistent bias that makes the workplace not enjoyable. Underrepresented students often request to meet with underrepresented faculty and staff. And these same faculty and staff frequently serve on multiple committees, resulting in burnout. However, the non-minority employees feel comfortable and valued. Now let's compare that to Organization B. Organization B is made up of diverse individuals throughout, including within their leadership positions. The organization has made intentional efforts to hire and promote traditionally marginalized groups, and they have implemented a formal mentorship program and affinity groups. The organization serves a diverse community with improved health outcomes. DEI are included in their mission, vision, values, their strategic plan, and their metric dashboard. Non-minority faculty staff are educating themselves and growing in the area of DEI, and they are also actively involved in DEI and A efforts. Inequitable and non-inclusive policies and procedures are updated accordingly. Data is being collected and assessed. The faculty, staff, and student evaluations and climate surveys are above average and improving. The majority of the employees are engaged in this work and they serve as accountability partners. So I want you just to reflect on the difference between Organization A and Organization B. What we may call Organization B or their actions performative. Versus B, they are walking the walk. And so I want you to think about the institution that you're in and how you might help them to be more like Organization B. Certainly Organization B has not arrived, but they are making efforts and strides in this journey towards anti-racism and inclusiveness. I believe that whatever matters, you will measure. And so I'm sharing a tool that my institution uses, and I highly recommend this particular tool. It's the Myer DEI Spectrum tool. And this particular tool is a systematic approach to evaluate an institution, and it could be any institution, a hospital, a school, a department. It evaluates on 12 different dimensions. The components basically are, it's a 5-point scale, not yet started, to exemplary leading. This particular tool helps to identify gaps and also priorities for the future. It may be used as a way to monitor progress. It's critical for institutions to understand where you currently stand, and you can use this tool to help move you in the direction of actually being exemplary or leading the way in this particular area. Now, I've talked about a lot, and I want to share some additional strategies to pursue inclusion, diversity, equity, anti-racism, not only in pharmacy, but in healthcare in general, or in this society in general. So first off, I talked about the importance of understanding or recognizing the issues that are occurring in our country, that are occurring in the institutions that we are working, that are occurring in the communities that we live, and learning about those structural and systemic barriers. In order to dismantle structural racism, we have to know what it is. We have to believe and accept that it does exist. In order to disrupt the cycle of this racism in our workplaces, we have to be that active anti-racist. We're working against or going against the flow. We have to also understand how the social determinants of health affect our patients and educate ourselves and our students. Creating a space for sustained dialogue on anti-racism, implicit bias, and how to collectively dismantle systemic racism. One way that we can, this allows us to really start noticing the racial dynamics on a regular basis. Once we learn to always notice race, who's in the room versus who is not, who's at the table, who's constantly speaking, who holds power, then we can start to be aware of our own role in those situations. This awareness is a critical step in analyzing the possible complicity and devising strategies to interrupt racism. It's also important to discover and identify those personal biases, how they show up, and unlearn them. So just like we learn them from loved ones, from the society, from messages that we received, we can also unlearn them as well. We can discover and identify those biases through the implicit association test or through the cycle of socialization to understand why we think or feel the way we do about certain individuals. Really taking note on what you're thinking when you're interacting with certain individuals. Our biases can contribute to these health inequities, and they can result in a patient not seeking medical care because they feel that they will be judged, discriminated against due to a lack of trust. So it's important that you check your biases and ask the question, are you being judgmental or saying stereotypical things to a patient? It's also important for us to move from being a bystander to an ally and sponsor. And so being an ally, that's an action. We must be prepared to engage colleagues when they misstep or offer support to individuals experiencing microaggressions or discrimination. Before directly confronting an offender, we should pause, give that individual being targeted a chance to respond. If it's clear that the individual is not prepared to respond in the moment, directly respond to the offender to let them know their behavior or language is not appropriate. And afterwards, check in with that individual who's been targeted and ask them how they are doing and what you can do to help. A sponsor is someone who actually brings along a historically marginalized individual, brings them to the table, presents them with opportunities. So knowing that individuals have been historically marginalized, finding ways for you to actually sponsor them and present them with opportunities they may not have ever been exposed to. We want to also view patient encounters with an equity and trauma-informed care lens. So as I mentioned earlier, instead of thinking or saying what is wrong with the patient, what is making them be so difficult or closed, change our questioning to what has happened to the patient. What has this patient had to overcome, or what are they dealing with? Understand the why. We want to be mindful of both our verbal and nonverbal communication with patients. We want them to feel comfortable and not view us as a threat or view themselves as inferior. It's important for us to engage minoritized individuals as shared stakeholders. I like to define diversity as representation, or diversity as having a seat at the table. While inclusion there is representation of various demographics, but there's still isolation potentially, because we may forget about those systemic barriers. However, belonging is being valued, encouraged to fully participate, and hearing their voice, actually amplifying the voices of those that have traditionally been marginalized. And so that's the goal of making sure that we are amplifying and engaging those minoritized individuals. Let our data drive our priorities and actions. As I mentioned earlier, if it matters, we'll measure it. Strengthen our advocacy efforts regarding health equity. And so that lends us to the community side, or the advocacy side. With that, we can partner with organizations within our community. Recently, I took some students to a homeless shelter to provide free flu vaccines. And this is providing them with a resource that they may not have ever had the opportunity to obtain. And finally, revising organizational policies and practices. So our policies and practices are what really causes us to operate the way that we do within our organizations. So thinking about, what are our hiring practices? What are our admissions practices? What are some ways that we can move from subjective to objective policies and procedures that will not allow biases to creep in? So these are a number of strategies, and it's certainly not all inclusive. But what I would like for you to do is to reflect on all that I have said during our time together, on what immediate and long-term strategies or actions do you plan to implement? Hopefully you've taken some notes, mental notes or written notes, and understand that this is a collective, or must be collective and consistent actions moving forward. This is a journey, not a sprint. Being in the restaurant asking, why are the people outside not able to come in? Go out and invite them. So I hope that I have given you all some nuggets to pack in your bag for use on your journey. I encourage you to join me on this journey of confronting health inequities and taking consistent action and steps forward. This is a journey that requires consistent forward movement and active participation going against the flow. And with that, I will turn it over to our guests, or to our host, regarding questions and answers. Thank you all so much for your attention and for being here.
Thank you so much, Dr. Butler, for that engaging presentation. You have definitely given us some prescriptions that we need to fill. And so I appreciate all that you've shared. And we do have some questions in the chat. One has to do with the racial battle fatigue that you mentioned. And I just want to thank you for your transparency in talking about your experiences with racial battle fatigue. And one of our audience members asked if there is any research or data about children ages 5 through 18 who experience racial battle fatigue?
So that's a great question. And I have to say that I'm not very familiar with the children's side of things. I'm an ambulatory care pharmacist, and so I actually take care of adults. But I could only imagine that it does exist in our children, and it may manifest in different ways. We've certainly seen during this COVID-19 era and the era of isolation, our students and our children have definitely been affected. So I would say, yes, it does exist, but I don't have a lot of information regarding that.
Another related question is, are there any studies evaluating the relationship or correlation between racial battle fatigue, high blood pressure, for example, versus the race of low and high income earners?
Yes, there are. I mentioned that this concept of racial battle fatigue was introduced in 2003. And so there has actually been a couple of studies that have looked at that correlation. And so I would encourage you, it makes total sense. There are a number of books. I'm actually reading one right now that talks about how to deal with racial battle fatigue and just the healing that needs to happen. I also attended a retreat just a couple of weeks ago for all of our DEI leaders, because we realized that we have been experiencing this racial battle fatigue for the last couple of years, especially. I can just recall, during 2020, being in tears, just constantly being in meetings and breaking down because of the anxiety that I felt. My heart was constantly racing, and I have not dealt with high blood pressure, but my blood pressure went up just slightly. It wasn't too high, but all of this is definitely affecting our patients. It's affecting us, and in order for us to show up, we have to definitely take care of ourselves. And so we went through a self-care series with a group that's called Sky, and they just walk us through these different techniques. And it's a lot of mindfulness and meditation. And I knew you would ask me that the title. I will get back with you on that. It's downstairs. I can't remember right offhand, but I will definitely share some of these resources with our host.
Another question has to do with the use of smartphones in conducting health research. Do you have any suggestions on how this kind of research can be done in such a way as to not exclude those from minority groups and others that might otherwise experience disparities in healthcare?
If you could share the first part of that question.
Let me read it straight from the Q&A. Just a sec. I've seen a trend towards using smartphones to conduct healthcare research. I believe this practice contributes to inequitable research. Do you have any suggestions to address this?
That's a great question. And, when we think about even just with vaccines, there's still the accessibility divide or the accessibility inequities with vaccines. Some people will say, well, they're available everywhere. But think about the individuals that have to work and they have other responsibilities. They may not have transportation. So there are still those inequities. And the same with this question. There may be individuals that don't have these smartphones to conduct the healthcare research. So it's important that we don't just limit our research to using smartphones, that we include, paper copies, email potentially, but also going into the communities that we're trying to reach and finding out ways that the technology that they actually do have, so that we're not excluding them. So making sure that we are thinking about all of the patients and thinking about the research participants. We don't just want what we've typically received. We want to be intentional. And all of this work requires intentionality. It requires that we say, I have typically had just the majority represented, but I want to have more minoritized individuals represented. So how do I reach them? And actually going to them and finding out.
Thank you, Dr. Butler. There's a question about universal health care. I'm going to read a portion of it from the chat. Do you have any suggestions for how we as employees in healthcare can mobilize to insist that our leaders call for national organizations and associations to endorse universal health care?
Okay. Let's see. I'm reading the question as you are reading it as well. That's a loaded question. Thank you for the question. Yep, I do think that it is important for national associations to be a part of the advocacy work as it relates to ensuring that everyone has access to healthcare. Let's see, once readily available as it becomes more officially accessible, debt for all. I know that healthcare is not cheap. It costs our country, millions, trillions of dollars. But I think I don't necessarily feel equipped to answer this particular question, but I will say that it has to be a joint effort with public health facilities, higher education. We have to come to a consensus of how do we address this best in a cost-effective manner. I'm a big proponent of let's utilize pharmacists more as it relates to healthcare. So I'm not sure if I feel best knowledgeable to answer the question, because it's a loaded question and it's a great question, but there are a lot of moving parts to what needs to happen with this particular area.
Okay, another question is, can you provide thoughts on how best the sponsor roll call can be initiated? How can we support this relationship while also avoiding white saviorism?
Great question. So I talked about ally and sponsorship during those strategies. And, I talked about the difference. Allyship is, you're actively involved in different activities. So you're educating yourself. You may be speaking up for individuals if they are experiencing micro or macroaggressions. But a sponsor is someone who, when an opportunity exists or an opportunity arises, they are bringing up someone's name and historically marginalized individuals, or they are providing that, it's a step further from mentorship. So mentorship is, I'm helping you to kind of determine your next steps, or helping you to develop goals for your career, or as a student. But a sponsor will say, okay, I am going to make sure that you get, you are able to run for a national office because I'm going to submit your name, or I'm going to submit your name for an award. Or when I'm in a room and they're looking for individuals for a job, I am going to advocate on your behalf. So that's what we need. And, sponsorship does not necessarily have to to be vocalized. You could be in a room and advocating on someone's behalf without them even knowing. And that's what historically marginalized individuals need, because oftentimes we're not in the room because of the, just the isolation or the lack of inclusion, especially in leadership positions. If we look at leadership positions across the country, they are, predominantly white. And so because of that, having those white sponsors in those spaces to advocate for anti-racism, to advocate on behalf of individuals that have been historically marginalized, that is what's going to help change the visual and the kind of the outcomes of what we're trying to accomplish. So I think you certainly can avoid the white saviorism by not necessarily always going to that person and saying, well, this is what I did for you, or look what opportunity I have. Certainly providing them with opportunities, but doing things behind closed doors and really advocating for individuals that can't advocate for themselves.
Another question is, there are several games online that help individuals uncover their personal implicit bias. Do you recommend any of these to help train students on this topic, specifically related to healthcare?
I am not too familiar with the games. I certainly advocate for the Harvard Implicit Association test because it's been tested. So I'm not sure if the games that you are referring to have been validated or tested like the implicit association test. So more so, I would recommend that test because I'm not familiar with the games. There's also an activity that I utilize in my class. It's called Trading Places. And what we do is there's 3 rounds. The first round, the students have to rank the number 1 through 12 of how likely they would want to trade places with the individual. And there's very minimal information during the first round. They get some additional information the second round and kind of a full vignette for the third round. And it helps them to uncover what were some of those first thoughts or biases that they thought regarding a patient with limited information. And that helps us to see what happens when we're interacting with individuals. So based on the minimal information that we see or know, that shows us, are we willing to trade places with them or how we actually view them? And so that's another resource that I like to use.
So do you have any suggestions on how health sciences colleges can work together? So at the beginning of your talk, you talked about the many ways that minoritized individuals have been discriminated against within the healthcare system. And you referred to the social determinants of health. And we, as a collaborating group of health sciences schools and colleges, representing the seven schools and colleges that I mentioned, can work together to attack some of these issues because we're representing the social sciences, the social work area, the public health, kinesiology in terms of movement. Are you familiar with any best practices within the curriculum? I'm not sure if you all have IPE at your institution, but we have it here at U of M, and I'm wondering if you have any suggestions on how some of these topics can be addressed across all of our disciplines with our students.
Yeah, that's a great question. And I think, the greatest way to do that is the social determinants of health. We've utilized a poverty simulation as well to look at the implications of socioeconomic class on, just someone's health, but also, holistically from an economic standpoint. I think it's also important during, IPE that we utilize maybe standardized patients that represent a variety of identities. So those are a couple of strategies that my institution has used. We also, think about when we're presenting patients. So, if you are maybe presenting a patient during rounds, is it important to provide the patient's race? If it is, then let's talk about why that might be important. So once again, digging deeper into those social determinants of health, of what may be affecting that particular patient and their health. So those are a couple of things that come to mind with the interprofessional side of healthcare. And I did want to go back to that racial battle fatigue question. So the book that I'm reading, it's called Black Fatigue, and it's how racism erodes the mind, body, and spirit. It's by Mary Frances Winters.
So I have another question that relates to pharmacy in particular. Dr. Mueller's comments related to how pharmacists are a first line. They are most accessible to the community members. And I'm wondering if you have any tips for pharmacists in terms of how they can be more engaging, how they can begin to dismantle and disrupt some of the racism that is occurring in the healthcare field.
Right. So, I'm a pharmacist myself, and a couple of things that I mentioned. So first off, it's important for us to do the self-awareness piece, to look in the mirror and to understand what we're bringing to the table as individuals, what messages, what unconscious biases that we have. But it's also important once we've acknowledged those, we're working towards dismantling or unlearning those biases, that we are building trust. Just minor things such as providing good eye contact. I remember going to a physician, and the entire time they were engaged on their computer. So that made me feel inferior. It's another strategy that I like to use is, I take my white coat off when I'm talking to patients, because I want them to feel comfortable. Certainly, maybe in certain situations, you may not be able to just because of the environment, but that's just, I think a very small strategy or step that can be taken to create a more comfortable environment for the patient. When I say building trust, that takes time and it takes effort. It takes intentionality. So finding commonalities with the individual to spark conversation, and asking them, what more can I do to help build our relationship as provider and patient. It's also about the language that we use. We have to be very mindful of, am I using marginalizing language and referring to this, making this patient feel even more inferior. So it's that nonverbal and verbal communication that we have to be very mindful of when building trust with the patient. So trust is a key element of what pharmacists, healthcare providers really want to be mindful of, and that trust cannot manifest through judgment. So I've been in the room where a patient will say, well, I don't take my medications every day, and I don't see the purpose of taking them. And the student frowns because they're thinking, why is this patient feeling this way? But let's find out what's going on instead of what's wrong with them. What happened, or what have they been told? What are they experiencing that's causing them to feel that way? So that trauma-informed lens is so important.
Thank you, Dr. Butler. Well, at this point, I think we're going to bring things to a conclusion. So I'm going to share my screen. Thank you for answering all of those questions for us. And I now want to formally thank you on behalf of the Health Sciences Committee and our Health Sciences Deans for being our keynote speaker at this 32nd annual MLK Day lecture. We appreciate all that you shared with us. I think you've given us some great prescriptions for change. Thank you for the things that you shared about your personal experiences. And we wish you all the best as you continue to disrupt and dismantle these inequities. Congratulations on all that you do in your business and at your institution. And again, we just want to thank you. And I want to personally thank all of those who were in attendance today. We appreciate your attention, and we hope that you have learned some things today about what to do and to not be a bystander in this work. I want to remind you that for additional information regarding MLK events at the University of Michigan, please visit the OAMI website. And we also hope that you will tune into our upcoming MLK Health Science Day events. Please stay tuned for a survey that will be sent out to you. We really value your feedback, so we hope that you'll complete that. And we hope that you will enjoy the rest of this MLK Day in celebration of his legacy. And thank you so much again for tuning in. This concludes our event. Thank you.